I'm taking a XT.
Any microcatheter help you want to take? Any microcatheter help you want to take?
It is a fine cross. It's a fine cross. What to take? Well, I usually prefer the fine cross because it is radiolucent. You have vision is much better of the proximal vessels. What is happening? I feel more comfortable with it, but Corsair is equally good. And sometimes the fine cross will not traverse the lesion, and when the wire has crossed, then I think the Corsair would work better.
Because here the calcium is there.
As a start, I always like a fine cross.
Okay.
I know, so with that calcium and with that CT information, that makes us wiser.
Yeah.
So there is a good importance of CT in CTO interventions. That's what I wanted to show.
For the knowledge
And
of
now
audience.
I'm just the XT has a very fine 1 millimeter tip that I have made to 45 degrees angle. And that is what I have done.
Is it crusade useful in this situation?
That is the XT that's coming up. Crusade, no. Crusade I won't use at the beginning. Crusade will come only when I get subintimal and then I want to use a second wire, then the crusade will come in play.
Okay.
Right now I think I'll only, the first catheter would be XT only.
Here, as per the algorithm, because the tapered
It has to be very.
and micro channels, and
You see the XT is 010 tip.
operator select
010 tip, and because I feel
proximal cap.
yeah, but cranial is not a good view to work,
But here in the proximal cap, that the tapering is unable to see this view. Can you take cranial help for the tracking the micro channels through the tapered tip of the proximal cap?
Not doing very well, but
So that you can place the fielder XT into the micro channel.
For the sake of a lot of our people here who are maybe in different stages of developing their CTO, the first and the most important thing is and of course you can do a PA cranial. So that's where you see the
that calcium
body
spot is there. I'm targeting the calcium spot.
Yeah, now he's targeting the calcium and he has the facility of doing a CT along with his
Can I see the right
angiography.
direction? Right.
So which is extremely helpful to know how much is the calcium.
And sorry,
Well, can you take a cross section at the level of
This
the
is what happens,
calcium?
actually scientifically why he selected the anti-gravity is
You are working.
here the tapered tip proximal cap, short
Channels
segment.
cut there, the
Information.
flow goes very fast. It is not moving.
Because of these algorithm, previously it was disturbed by so many HFs. So he selected the anti-grade. And it's the operator's fancy, whether we take fine cross or four side, depending upon the workhorse microcatheter they will select. Here, Dr. Goyal selected the fine cross microcatheter, and he wants to track the micro channels with the help of the fielder XT. Is it XTA or XTR, Dr. Goyal?
This is XT. This is XT.
Plain XT. Actually, if you take the XTA, it is very useful because of composite foot technology. It will track much more
Yeah,
effective than
XT I
micro.
use if XT doesn't go.
Yeah.
Right injection, please.
But they just
Make it single plane right now.
This patient
Single
had
plane.
small
Audio.
that was an advantage
Right
to try
injection.
and degrade. If it was too austere,
Good injection.
many times
Good
it just
injection.
would collapse and straight go retrograde. Because in too austere, integrate getting the austere may be difficult.
So the most difficult is the absence of intervention collaterals and the stumpless CPU, especially LED. This is the most difficult subset actually in the anti-grade strategy. But It is IVAS guidance because you can put the IVAS in the real time 8 French guiding technique.
I have a feeling it has gone.
Pardon?
I was feeling it has gone into the direction.
Can we check with the retrograde?
Cranial view,
Can
cranial.
we check with the retrograde shows?
And if
Biplane helps me.
contralateral injection guidance you can take, but the distal LED it entered or not.
Right injection in biplane. Right injection in biplane.
So this is the second most important point, that if you are doing an anti-grade wiring, it's best to always inject retrograde and see, because you don't want to extend any dissection if at all you have caused it.
Gone into the LED.
LED it went already.
Yeah, so you're good, very good. You have caused the stenosis.
No, you have to be very sure. You see, the thing is, it looks very good, but sometimes you find that it is. So one has to be very careful. One should not take it for granted at all.
No, you were
And the wire handling has to be. This is only rotation. I am hardly pushing it.
Okay.
Can someone show my hand movement, please? I think it's probably going on right now.
Dr. Goyal, already you entered the LED it seems.
Only rotation.
We can shift over to the other lab.
I think so.
Yeah.
I think so.
Other lab switch over.
No, can you?
Okay, you can shift to the other lab.
Yeah.
You just see this last shot.
Okay.
Can you check in the yellow cranial view?
Yes, it already entered.
Yeah, it's
2 lumen of distal LED.
So you confirm it.
Yeah, it is already confirmed. We will switch over to the next lab.
Yeah. Okay. And then when you come back, I'll show you the
Sure.
Sure.
Hello. Dr. Sridhar at Dr. Matsuo. Good afternoon. Can you proceed with the case history and strategy?
Yes. Show the first slide. First, let me introduce the. Yeah. Next.
We can,
Able to hear?
yeah, now we can able to hear.
Yeah.
You can show angiogram directly.
I will show this, please. Now we can show. Present, please. You can. Yeah, we'll start. Now we can discuss.
Yeah.
Okay. Can we see the right injection? before
Right
we
coronary.
talk?
Circ dominant, right coronary injection.
Right, not dominant.
No, but can we see
Right,
the
not
injection?
dominant.
Is it giving collaterals?
Yeah.
No, no collateral.
No collateral.
No, there is one.
Because it's extremely important to know from where the distal is feeling and where the collaterals are coming from. Very little.
So,
This system only.
Yeah.
Right, not dominant, no collateral from the right system.
okay. So septal collaterals are filling the PDA of dominant circumflex.
Yeah, long segment lesion and that distal site is ending in bifurcation.
Yeah.
So this is actually a primary case for retrograde approach because long segment and landing in bifurcation segment, and patient is also having a low GFR because
Okay,
of
okay.
limitation of using more contrast.
Okay.
So initially we start up going retrograde and you can proceed with that.
So can we know what is the strategy? Which collaterals are you going to use? We have not seen the collaterals that well, which is filling the distal circumflex. Can you show us which are the collaterals which are filling the distal circumflex so we can understand and the audience can understand what's going on?
No, maybe
Can you
that
show
was
us
a,
that?
that was a diagnostic. Now they must have taken with the guide
absolutely. So
catheter.
please show us the thing based on which you are going to proceed.
Can I go?
Yeah.
This is Coach Matsuo. Thank you for inviting IJCTO 2018. It's great honor and pleasure for me to perform procedures with this great staff, and I want to explain my strategy. And you can see the circumflex proximal CTO, and maybe the CTO length is long, but we cannot detect clearly the proximal side of the CTO entry point. And this patient has one more problem. This patient has a CKD. So, firstly, I discussed the first, we must decrease the contrast minimum as possible as we can. So I started the retrograde approach firstly. And today's diagram from the guiding, only too short. This is our order view. From our order view, we could not clearly, we could not see the entry point of CTO, but we could see some central channels to circulate to the circumflex distal PDA. But this patient already put the stent to the distal circumflex, so I choose the distal septal channel 1. And please give me the other next view. And only this image, we can see a little bit entry point of the circumflex CTO. Stop. Sorry, stop.
Yes, sir. Please.
You can see.
The beginning. Stop. And a little bit close. Yeah, this one. You can see the small branch to go down straight. And you can see a little bit bending to the left side. So, me and doctors, maybe this is an entry point of CTO. But only undergrad approach is very difficult, and maybe only undergrad approach we need so much contrast medium. So started the retrograde approach. Okay, next please. And advanced the fine cross and the CM group and check tip injection, this is our caudal view.
Yeah.
And advanced wire, but around there cannot advance easily. And easily to the left side. But this is not the cause. So, next. For the next page. And a little bit advanced fine cross and check the tip injection again. We can see the connection to the distal PDA. And along this side, I change the wire to the XDR. And finally I could cross, like this.
Why you preferred XTR over the Cyan
Because,
series?
This channel is very small and channel size is very small, so I changed to the XDR.
Okay.
And why did you use a fine cross? Because most of the time we use...
Because this case is left dominant, so I don't want to induce ischemia already. So I want to use a low profile microcatheter.
Okay.
So these are very important points.
Yes, this is a lesion. And next please.
Dr. Matso, we have Dr. Galassi from Italy with us. We would like him to comment on what's going on. Dr. Galassi from Italy
Yeah,
is with us on the panel. Yeah, Dr. Galassi.
No, yes, I think that yes, of course, it's a retrograde case and is masterly taken this collateral, nicely taken by Sion and by Filial XTR, and I fully agree that it will be probably the best solution to reduce the amount of contrast, also because the distal CTO target is very small and so antegrade approach will be very difficult. So I think that is a really nice demonstration that retrograde in this case is very good. Of course now we need to know which size is your guiding, 7 French?
yes, 7 French.
Okay, because now of course comes the issue whenever you get again into the left system, how to handle the situation. Of course we have different solution and we will see now.
Finally, we need externalization. So
Yes.
if we need externalization, reverse cut, I want to perform double guiding technique using another guiding.
Yes, this is called ping-pong technique, or probably we can also use, if advancement is easy, we'll see, it depends on the situation, we can also advance just a standard microcatheter and try to regain in the rendezvous technique the wire.
Okay.
Yes, of course, I mean, we will see now.
Just for a discussion, what are because we are going from the same guiding through the collaterals, ipsilateral, and we have to now catch that wire somewhere. So what are the different approaches that you can employ here? One is the second guiding and then you try to get into a second guiding.
Yes, one is the second guiding, which is maybe probably done when you have a 6 French, and so you can have a 2-6 French guiding. So ping-pong technique is a standard, is a technique. Or if you use 7 French, usually I do the same. I use 7 French, and I prefer to do, if I can go back with the wire inside the guiding, I advance in antegradally in the same guiding, the same 7 French, a microcatheter, and I'm trying to regain in a rendezvous technique the wire that is inside. So these are 2 possibilities. Of course, trapping is not possible with one single guiding, so that would be difficult. It's impossible because if you advance, you cannot push the wire.
Second guiding, I think, is a much easier way of doing it.
Second guiding may be done also with a 6 French guiding, and then it would be nice ping-pong technique. So we have 2 different possibilities. Most of the things depends on the progression of the wire, because if the progression of the wire needs to have some antegrade wiring, of course, double ping-pong technique is a must.
If initially 8 French guiding catheter is taken, then need for 2 guiding catheters, is it necessary, or just with 8 French working guiding catheter?
Well, nowadays we don't use 8 French guiding anymore, so I would suggest that as the doctor is doing, I would say from 7 and 6 would be good for as a ping-pong technique.
No, and in the Indian situation, the size of the left main also matters. Not all left mains accommodate 8 French guide catheter.
Yes.
So in that case, it's better to play safe. like we saw in the morning, the guide catheter got damped and the pressures dropped and almost an arrest was there. So I
Absolutely.
think
Point-
taking
your
two
point
guide
is well
catheters
taken.
is a better option,
Yeah.
and you can always disengage and engage accordingly.
Yes.
The other problem with single guide catheter is pull and push. You know, when you are externalizing the wire with the same guide catheter, then one has to be very careful that the guide doesn't get sucked in.
So because it is bulky, it becomes difficult and sucking, and it may produce left mind damage.
Yeah.
Okay. Okay, Dr. Matsuo, next what is your
Galassi,
stand?
can two microcatheters go through 8 French?
Yes.
One antegrade, one retrograde.
Yes, also with the 7 French you can go with 2 microcatheters.
Both corset?
Yes, yes.
Two fine cross can go in 7 French, one corset and one fine cross cannot go.
One corset,
Then
one
it becomes very difficult.
See, these are very important instructions. You can have two microcatheters going through the same 7 French. You can have one corsair and one fine cross, but you can't have two corsairs probably through the same 7 French. So these small points will help you to sort of avoid the mistakes which
Yes, yes.
people have done before and have learned. So you have the chance to learn it without doing the same thing.
Okay, Dr. Matsuo, what is the next step you are going?
Okay, next step is question, the next one, question. From chip injection, we cannot clearly detect the vessel force. You can see the next one, please. Yes. And so I performed from the guiding and microcatheter simultaneously. Next. We can see like this.
Yeah.
So very long.
But
maybe
micro
I see-
channel.
Yes, you
Yes,
are.
but more promising now
Yes, you
than
are.
what we
So-
started.
Okay, so it's I agree. Like this situation, I decided to advance the wire from the retrograde and antegrade both wire. Next.
So one of the question I have, Dr. Matsuo, for you is, how sure are you that this is a retrograde connection and it's not a collateral which is joining the end of the CTO to the distal?
I'm sorry, I can't.
The question is, you have one small channel which shows you a connection between the
Distal and
distal stump and the proximal stump.
Yeah.
How sure are you, or how do you make out whether this is the channel, it's a true-to-true connection, or is it a collateral, like a bridging collateral?
He is anti-gradely going.
How do we make that difference?
It's very difficult. Well, from the diagram, I think maybe this case has a
No, yeah. No, I understand. See, that the thing is, this case may be like this, but another case you may have a problem that it may be joining from the side. So you have to be sure what you're doing. So just for I wanted to know from you, how do you make, can you make a difference?
It's a difficult question. But I take it from
The antegrade wire is
What is anti-grade wire, Dr. Matsuo?
Yeah, so... from
Anti-grade
this-
wire.
Yeah, from this side antegrade wire. For example, antegrade
Yeah.
wire.
Ah.
Little back. This one.
Yeah.
Very bending there.
What is a wire you are used? Anti-grade
So,
wire. Ah.
Firstly, I use the Sion.
Anti-grade.
Antegrade.
Yeah.
And from the antegram, maybe around the severe stenosis there.
Yeah.
So I switched to the XDR.
XDR.
Big bending. And final cross.
Yeah.
And very smoothly go advance a little bit this side.
Right.
And a little bit advance the fine cross again.
Yeah.
And like this. And this side, I tried kissing wire.
Yeah.
Because from the rotational antegram,
Ah.
my both wire, the course is very close and very good direction.
This is most important actually. It will answer your question also. If it is a mini micro channel, when you are doing rotational angiogram, it is classically showing the connection between the distal cap and proximal cap.
Both the wires are moving in tandem, so
plane,
you know that they are in the same sort of architecture of the vessel.
Plane.
That's the way to identify that your antegrade wire and the retrograde wire are in the same architecture, vessel architecture, because they are moving together.
and they are in the true lumen now.
Yes.
Because the antegrade wire is coming from the true lumen and the retrograde wire also.
Natural cell, it is a micro channels, it is tracking.
Yes.
So that's why, that is the technique actual filter XTR. If you take as a first grade, anti-grade choice, it will track the micro very nice because of taper tip as well as the lubricity, it will track.
Yes, and like this station, if my wire cannot advance easily to the distal side, maybe like this station, I can perform roundable technique.
Yeah.
But using XTR from this side, my XTR fortunately advanced to the distal lumen like this.
Yeah.
And advanced fine cross and switch to the symbol now. So from this now I want to direct it there.
So it's an absolutely excellent demonstration how carefully and
Tracking
without
micro
any
channel.
very minimal dye, Dr. Matsuo has been able to cross this lesion, both actually retrogradely as well as with the help of the retrograde injection, cross it antigradely with the help of the microcatheter, and he has been able to enter.
Okay.
Can you just ask the question on the mic,
Okay,
please?
yeah.
Yeah.
No,
No,
because-
first,
Yeah.
No.
Yeah,
he,
Dr.
has to
Yadav-
minimize, he wants to minimize the contrast with that. Yeah. That is not a bad idea. Actually, he can start anti-grade.
Yeah, but we were not very sure which is the antigrade.
Integrately as well.
Already the reason was he was not very sure which is the entry point for antigrade. That's why he said, that is why he said he does not want to waste contrast, because if he dissects there then he'll have a problem. Moment he went retrograde very easily, the retrograde injection showed everything very clearly, so it was very simple then.
What?
It looks very simple when everything goes on well.
No, Kanisam. Dr. Yadav is a valid point because the proximal cap is a tapered one if you carefully see. And some visible mini micro channel is there. That is the point. But it's the operator's choice.
Yeah, but
usually.
he said he did not see that.
Yeah. You are absolutely correct.
Dr. Matsuo, you want to comment on this, because there is a comment from the audience that why did you not start antigradely right in the beginning?
From the beginning, starting the antigrade is not good for the patient. If this patient does not have a CKD, from the antigrade is okay. But you can see from the angiogram, the entry point of CTO is not clearly, and maybe the only way is very difficult, and we cannot see clearly the point.
I fully agree with you. If the operator himself is not sure, you can't say that you tried.
See, once the retrograde wire reached that point, it looked simple.
Then it looks simple, absolutely. I fully agree with that. Yeah.
And Dr. Yadav,
Absolutely. In this particular patient, it's absolutely makes good sense. I feel so. Yeah.
No, and we are not losing anything. The retrograde looked quite clear enough to get the axis. So it was not a difficult retrograde where you had to push in again more dye.
Absolutely, absolutely. Yeah.
Good intervention collaterals are there.
The good interventional collaterals were there.
And one of the good thing about retrograde is you can make small injections to the microcatheter. You don't require a lot of dye, because you are not injecting in the left vein now to see the whole retrograde circulation. You can make small 1 cc injection through the microcatheter, which gives you the full retrograde circulation. So you save on dye. So it's very important when a patient has a CKD or a renal dysfunction. Otherwise, we keep on injecting sometimes in the...
No, even LV dysfunction patients. If you have LV dysfunction and you use so much of contrast.
Hello, Dr. Matsuo, already you crossed the CTO segment, we'll switch over to another lab, okay?
But please show us all the things that you have done from
Steps.
this point. Yeah, all the steps. Yeah.
Right. Thank you. Next, switch over to Dr. Goyal. Dr. Goyal. Hello?
Yeah, hello.
What is the next steps you have done after crossing?
So, welcome, Dr. Galasi.
Galasi.
Welcome, Dr.
So you were not
Goyal. How are you? Nice to see you.
Yeah, good, thank you.
Still in Lucknow?
Nice to hear from you.
Dr. Goyal said he will not complete the case unless Dr. Galasi comes.
You are still in Lucknow. You did not change the city.
When I
Yes, yes,
there
yes.
were some micro channels it seemed in this lesion.
I saw it.
And we did a CT guidance also. We had the CT on the side, which helped us to get the exact anatomy and know where the calcific spots are. Actually, if you see, the CT showed us very nice calcific spots. The occlusion was proximal, and the diagonal which was coming there was a calcific spot. So we could wire, and I did it in biplane. I usually wire in biplane. So we did it in biplane, and we could. I think you saw the wire last when it was going in. Can you show from the point where they had left?
Cross the wire.
Okay.
See, biplane also helps in reducing the contrast. If you have biplane,
Get the boxes.
A very nice picture.
Get the boxes. So this was the lesion.
Yes, it's very nice picture.
Can you show the first original lesion? Original lesion दिखा दो and then original दिखा दो. First पे चले जाओ. है ना? Original दिखा दो.
Bilateral angio, you have shown, huh?
Yeah. दिखा दो.
Dr. Goel, we want to know all the steps because you have done an excellent job, so we want to see all the steps in clear. Please explain all the steps.
Yeah, I'll just show you. Yeah. Can you just... We have to go to the first one.
अरे आप फ्लोरो करो,
Okay.
प्रवीण साहब आप फ्लोरो करो और उसको माइनस करो.
हाँ, अरे नहीं.
He's always the same. He's always the same. He's never changed.
One thing I want to ask Dr.
No, you explain
This is
that,
what the
Dr. Goel,
lesion
sir.
was.
Yeah.
Yes,
Okay,
yes.
next. Just go next. Okay. That's the diagonal which was, that's actually a ramus type vessel which is patent, which is coming right from the left main division. And so this is where it was. Next, go forward. So the point where the diagonal is filling retrograde, at that point there is calcium. And the occlusion is before the diagonal joining. It was about 20 millimeter long as per the CT and our angiogram. So next forward. So that is forward please. So that is microcatheter in the proximal stump. And this is where we started the XT. And it took us about, I think the XT handling took me about 4 to 5 minutes continuously working on it. And we are very gradual. You can see the calcific spot on the lateral angio, if you can see the lateral angio. And so we are trying to stay away from it. The CT exactly told us where the calcific spot is there in relation to the artery. So I kept the wire right of that. And next. And keep going. So gradually move forward. And with the guidance of the retrograde injection. Actually, the mid part of the LAD is not filling very well. We now know it after having completed this, after having crossed and balloon dilated. There's a lot of disease probably in the mid LAD. Next. So still that's the fluoro of the XT, which I am gradually moving forward. It's gradually moving forward. And next. Now, so, and biplane injection, because sometimes it's become my habit to use biplane because we have biplane. How it helps us is that when it is moving in one direction in RAO, I can immediately see simultaneously where it is in LAO. Otherwise, when you physically move it, sometimes the wire tip moves somewhere else.
So one of the ways of saving dye.
You can immediately know every direct here. Yeah. Keep moving forward.
Goel, we were just discussing in the other case, Dr. Goel, Dr. Goyal, we were just discussing in the other case, in the other lab, how to save dye contrast injection. So biplane may be one of the ways of reducing contrast load. Is that correct?
Yeah, so I have to do only one injection. So biplane gives me two benefits. One, the contrast use is less. And second, it can tell me where the wire is in two planes.
Two planes.
So that is very important. And now it was true. So now move forward please. Now move fast. So once it is move forward please. And then once the wire is through, I have changed it with a trapping technique to workhorse wire, did some balloon dilatations, move forward. And now because I crossed the lesion, I had time. Move forward please. Move forward please. Okay, so those are some balloon dilatations, bigger balloons, longer balloons. Go forward and show some angiogram. So there's some disease there, you see a dent. And then, so more disease, a lot of disease this again. That's why we were not able to fill the whole thing in our diagnostic angio, even with a combined contralateral angio.
So one thing one question from the audience is, do you need to keep the right-sided catheter once you have crossed this, or should it be removed, and when it should be removed?
No, now I don't need it. It is.
No, this was one of the questions raised from the audience.
We have already. Once we have crossed, we don't need the right-sided catheter, and we will remove it. There's no problem.
Dr. Goyal, I have two questions.
It is not only once you have crossed, but once you have antegrade flow, then you can remove. You see, it's not only crossing. You may have crossed the wire, but the antegrade flow is not there. Then again you have to take retrograde injections. So unless you have established your...
In this case, we have got the antegrade flow. After balloon dilatation, you actually will take it out after the balloon dilatation, and you have seen that the flow is there. Sometimes you have done some balloon dilatations and there are some branches that are still not filling. So all those things are there. So I take it that for granted.
So at least once your job is over of the retrograde thing.
Stent it. So actually I did some OCT pictures. If you want, I can show you some good OCT pictures. So can you just show the OCT please? Because once we did the balloon dilatation, then I wanted to size this vessel for stenting. That's something other than CTO, because we've done the CTO part.
Dr. Goyal, other than the size, I would be interested in the length of your stent, because you have a diffuse disease. So I'm more interested in the length of the stent rather than the size of the stent.
Yes.
We can switch over.
Size is also important and length is also important. So we did. Can you show the first OCT run?
Dr. Goyal.
So now you see the first OCT run, and there are some dissections in the distal part of the vessel. And the size.
Dr. Goyal, we'll just come back to you because there's an interesting thing going on in the other lab. He has just crossed. So we'll just come back to you. Please keep all these things with us.
Sure. Okay.
So please shift to the other lab.
So, Dr. Goyal, I have some...
Dr. Matsuo, what are the next steps you did?
Please start from where you left us.
I directed 1.5 firstly, but I could not advance IVAS, so I directed using 2.5 arrow. And from this time, I want to advance the stent, overlap, and distal stent. So firstly, I want to use 2.5 arrow, please, again.
Okay.
Please again, 2.5 arrow again.
We can.
I want to direct the inside of the stent.
Okay. For the interesting of the audience, Dr. Nasu, very difficult case, he crossed the antegradely. Now he is doing reverse cut. Can we switch over to that Hyderabad lab, please?
The morning case where we
Morning
had,
case, which is very difficult. Longest CTO from ostial RCA to the bifurcation of the RCA, that is PD, and what are the...
So if you remember, he was trying to get an IVAS guided antegrade puncture, but with 7 French, he could not get the IVAS and the puncture microcatheter together. So finally, he wanted to do an antegrade puncture without IVAS guidance. And there was a lot of difficulty going retrograde, where he had tremendous change of so many wires and catheters from SO3 to cyan to ultimate Bro 3 to cyan black, and finally he came back to Sion. So there were a lot of issues in that case. So where is he? Are we with Nasu, Dr. Nasu?
Sure.
Oh,
Yeah.
after you.
Sorry, audience. Actually, that recorded CD we can play in the evening because only it is a transmission time is 1.5 hour. Beyond that is not possible. Now we can go with the Matsuoka case.
Sorry.
Dr. Matsuo, can you tell us please what you did from the time you left us last? Can you tell us what all things were done since the time you left us before we shifted to the other lab?
After antegrade crossing with the XTR.
How did you use the second guiding? What did you do for the retrograde wire? Because we were thinking that you will use a second guide catheter to get the retrograde wire in, and then he crossed antegradely only. So he did not have to use the retrograde.
Yes.
Okay, sure, yeah. So we could not see that double guiding and all because fortunately he crossed antegradely. So that question did not arise. Barabar.
Sridhar, can you explain the steps? He is busy in technique.
Sridhar Kasturi.
Give me 7. Give me 1 7. Give me 1 7.
No, can they hear us?
Dr. Sridhar, can you explain the steps?
L6 again, process dilated 2.5 members.
Okay.
And stent was dilated, IVS was done. See,
Ah.
IVS is showing almost L6 3 mm diameter weather.
Okay.
Now we are implanting it 2.5 to 48, the longest, that is Science Expedition Stent.
Okay. Can you show the IVAS? What are the findings? Can you concentrate on the IVAS?
Just show the IVS.
Sure. Yeah.
So once they implant the stent, then we'll show the IVS done.
Yeah.
2 4 6 8 10 12 22.
Yeah.
Yeah.
You can take this one.
So what's the strategy for that bifurcation then?
8
OM and the circumflex.
8 10. Yeah. OM, the
Yeah.
application is okay. Maybe. I already insert wire for the probe technique 2 4 6.
So you will just cross over single
Yes.
stent? Yeah.
From the IVAS imaging, I want to do the stent crossover. Okay, please give me the epicola.
Come to epicola.
Epicola. Sorry, I want to quickly finish this procedure because we can find the hematoma, the puncture site. Okay, 2 4 6
Okay.
8 10. Yeah.
The femoral puncture site you mean?
Okay, down.
Yeah,
femoral side, right femoral side.
Like that. But patient is absolutely stable,
Yes, stable.
wider and no complaints.
Okay, should be the running again. Maybe around there is the stent. Its length is weight.
I think another party.
What length is stent?
This is party. Okay, another party.
Pressure is the epicola. 48 is 1 more 48.
Yeah, one more party 8 would be fine.
Yeah, because around here is
Small
the
patient.
stimulation.
I think that will be sufficient.
Okay.
Yeah, that will be
48.
sufficient.
Okay.
Give one more party. You want 3? 3 to 48 expedition.
Yeah, please.
So one of the important things in such CTO cases is to get a good femoral puncture without any hematoma. Because otherwise it spoils your mood throughout the case with one assistant just pressing upon the groin. And then when you're losing blood at the groin, you don't know the hypotension is because of the bleed there or because of your procedure. And that's why if you see the Japanese live demos, they all do ultrasound guided femoral
Yeah, come on. Okay. You can pull back. Record. You can consider the IVUS. Show the IVUS. You can see the post-stenting IVUS run. I think distally needs to be expanded.
This is inside of
Now it's nicely expanded stent, but needs some more.
I think you need to do some sort of over expansion.
Needs some more expansion.
okay.
Post dilatation is required.
Sridhar just wanted to know what's happening near the LCX ostium.
Just show the LCX ostium.
You're standing away from the LCX ostium.
Away from the LCX ostium.
Okay.
1, 2, 3, 1, 2, 3, 4.
I think we'll take 3.5 and
Yeah, 3.5.
3.5 NC.
In a C, yeah.
So we'll go to Dr. Goyal for 5 minutes and come back last 5 minutes to you because there are total 10 minutes left. Is that okay?
Okay, sure.
Thank
Okay,
you.
Thank you.
So can we shift to Dr. Goyal, please? Dr. Goyal. Dr. Goyal.
Dent नहीं होना चाहिए ना बेटा. Yeah, hello.
We have 5 minutes with you because the
Yeah,
time is...
so I have actually, I will show you the last angio.
Please.
And
Whatever
I have
interesting that you can show and
done
tell
a
us.
OC. Okay, so can we see the last angio, please?
Beautiful result.
Okay. You see, there was a lot of distal disease, so there was, which was also seen on OCT, there were some dissections in the distal part. Can you see the OCT? Can you see the OCT? Can someone show the OCT? Okay.
Now we can
So this is all mid-LAD beyond so a lot of dissections, and the size of the artery is not too big, about 2.5, negatively remodeled artery. So with that, after having put the proximal stent, I decided on putting a second stent distally, and we did that, and then we did and then we did a
Repeat OCT.
final angio. Can we see the final angio? Just show me the last 4 angios. Last 4 angios. Dribble karo. Last 4. Back karo. Minus. Minus karo. हाँ. No. देखो. हाँ? कैसे दे? लाओ. Give me contrast pure.
Beautiful.
Give me pure contrast, please. बेटा कहीं से दे दो ना मुझे आसानी हो जाएगी. So that was. Can you just hold on?
The angio result looks excellent.
There
We'll
was
do the
after
final
having put
OCT.
2 stents, I'll just show you. This was the disease beyond even after the second stent. Now that is the thing which made me very puzzled. How long can we go? So then I did some balloon 1.5 long segment. Go ahead please. Okay. So with balloon there was some improvement, and then we did some nitro and all, and so that was the final picture. I have accepted that picture, and now I just wanted to confirm on OCT. Now that's the final picture. Okay?
Yes.
In fact, so that's the final picture. Okay?
Yes.
So now I just want to do one last OCT of the proximal position of the stent to confirm that the stent is not jutting into the left main, and it is in a reasonable position, and we are not missing the LAD ostium either. So can we do it now? Inject. No, it has not come. चलो इससे कर दो.
Good opposition.
The picture hasn't come so well. I usually do it with colloid, but the OCT guy tells me that you use pure contrast by hand. Let me see what's happening. Are you ready? Tell me if you are ready. Auto calibrate, just hold on. Just bear with me and I think you will see something good hopefully. Enable pullback. Inject. Okay. So, that's it. Can you see the OCT now?
Yeah, it's a good
So
opposition.
that's the stent proximal part in the occlusion. Okay.
Okay, Goyalji.
And we will see the circumflex coming. So that's still the stent is there. More. That's the circumflex coming and the stent ends. So it is just a costume, not getting into the left hand position. And I think it's, yeah.
Okay, we'll
Thank
switch
you.
over to next.
Thank you.
Thank you, Dr. Goyal.
Can I ask you just one last question?
One question to you, Dr. Goyal.
I would like to understand, I would like to ask you, how many times you use biplane instead of single plane, and how many times you use CT scan for CTO?
Okay. Biplane, whenever I have wiring for CTO, what I do is I take a biplane, usually fix two angles and play with one of the RAO angles into apicaudal RAO cranial and do biplane for wiring. The moment I have crossed the CTO lesion and my wire is through, then I will get the biplane back and go back to single plane because during wiring it is helping me in directing the wire and reducing the number of injections. And once the wiring is done, then sometimes biplane becomes more of an obstacle because the limit gives you some limitation in angles. And sometimes to place the stents in the right position, you need to see osteums and orifices here and there. So you have to play with angles. So that freedom sometimes gets limited. So I use it specifically for this. CT, well, I used to use it less, but now off late, since the time we have got this software, we are trying to use it more and more, and I am still not able to overlay it on a live fluoro. I would say we are trying to improve on it, and let us see how far we go on it. But the CT picture on the side does help me in locating where the calcium is, how long the occlusion is, and which way in a general direction to get the wire and to understand the anatomy very well.
Okay, thank you very
Is
much,
that,
sir. And we now shift to Dr. Matsuo.
Thank you.
Dr. Matsuo,
Yes,
you are doing bifurcation again?
Troca, please. I can hear. Why? Can I?
Go to the views. Go back where we have looked. Go back. Yeah, I think. Go back. Yeah.
Okay, after putting the stent.
From here you can show. Next.
This first one, I put the stent 2.58, 48 lines.
Yeah.
And then I use 3.048. And after putting the stent to the proximal side, a little bit occur the shift, plug shift, carina shift maybe. Show me the angio, like this.
Yes.
So
Ostial pinching.
I want recross to the OM and finally perform the KBT. But the patient blood pressure is a little bit low, maybe the hematoma, a very big hematoma. So I want to quickly.
Yeah. Brother, get me 2.5 and that will go easily.
Doctor, please talk. Okay. This is 3.5.
This is 3.5.
This is 2.5. Okay. Oh, it's difficult.
It will take one
So
time.
first
It will cross easily.
Okay, here 246. This one 246. 8, 10, 12, 14. Okay, down please. It's difficult to cross.
You have to take a low profile balloon.
Yeah.
Take low profile balloon.
Yeah.
Take 2.5 10 or 1.52.
1.5 please.
Open the stud and then go with the bigger balloon.
Okay. He's okay? Because the infusion.
I Otherwise,
Oh, you study? Okay, okay.
Tajuna,
1.5.
keep 1.5 Tajuna
1.5,
ready.
please. Okay, please. 1.5.
Give 2.5. No.
This is 1.5. Yeah, yeah.
Give, what you do, 1.5 first dilate, then put the 2.5. Give 1.5 first, Tajuna. No taken.
Oh, we have 1.5.
1.5?
Offer. New one?
Yeah, new one.
Oh, thank you.
Call the anesthesist to inside. Narrator bed.
Dr. Kasturi,
Yeah, tell me.
no, see the flow is established, antegrade flow is there, just hold on for some time till you get the pressures up and then maybe do that kissing balloon.
Yeah.
Here, from here the screen looks the blood pressure is around 60.
No, actually, because now it's just
246.
quickly we can finish and
18.
come out. I don't think.
8, 10, 12.
No.
Quick, quick. 40.
Not for that.
Okay, down. Okay, again, 40.
That's fine. You can remove.
Okay,
It's fine. Remove it.
okay, down. Okay, please, 2.5, please. 2.5.
And then 2.5 balloon fast. Quickly finish it. It will be fine.
217. 217? Okay, it's okay. Because almost finished. This is 2.5? Please give
Kissing
me.
balloon, that's fine.
Yeah. I want to finish quickly.
Only that initial balloon was not crossing because studs
Is
were not
okay?
open. Then low propel balloon to
Keep.
open the studs, and then we are putting 2.5 balloon into the OM and 3.5 into the
Okay,
L6 and
I got
quickly
it, I got
finishing, kissing and coming out.
Okay, I got it. Okay.
Yeah, slightly pull it.
First week, 246. 46, 8, 10.
Yeah, this one also.
Okay, down. Down. Down.
Yeah.
Oh, wait. Okay, both.
Do it.
2, 4.
Both.
6. Only 6. Okay, down.
Reflex.
Straight. Okay, first we the OM, this one only, 246. 4, 6. And then you,
Do it.
246.
Do it.
Okay.
Bas, I think pull both balloons, that's fine.
Okay, down.
That's fine.
Okay, that's enough, I think.
Pull both balloons, then it will be stable. Yeah, that's fine.
Okay, check the angio again.
Slightly disengage the catheter, I think that would be better.
Kasturi, one of the suggestion was that maybe at the end of the procedure you can do a balloon
Thanks,
He's bleeding
you
or
can pull
something.
again,
Okay,
disengage the catheter.
show me the angio.
Can you hear us?
Show the angio, brother.
Okay, ready?
Good.
First class.
Okay.
Fine.
This looks quite acceptable to us here.
Acceptable.
fine.
Yeah.
Yeah.
Okay,
So
very good.
Dr. Sridhar.
there was a suggestion that you should do a
Right here.
balloon tamponade of the femoral artery as you're coming out. Will that help
Hematoma reduction,
for the hematoma?
Okay, please.
non-progression of hematoma.
Please. This sir, please show me the this.
Yeah, fine, really good.
Okay? You want to dilate the inside of the stent more?
No,
it's
no,
okay?
it's
Okay.
fine, it's
Okay.
fine. We can remove.
So I want to finish this procedure, okay?
Yeah,
And I
okay,
want
okay,
hemostasis.
Thank you
Very
very much.
nice
Thank you so much.
procedure.
Thank
Excellent
you.
demonstration.
Thank you.
Sridhar,
Okay.
Yeah,
Suggestion
thank you
that
all
the
of you
balloon
for giving,
tamponade of
thank you
puncture
Dr.
site.
Kapati, Surya Prakash for giving this opportunity.
Hematoma.
We wish you a very pleasant and great day in Hyderabad on behalf of Sunshine. Thank you one and all.
thank you.
Right, thank you.
Thank you so much. Thank you. Thank you. Thank you.
But a pressure line to press.
Thank you so much.
Okay. निकाल के we'll take injection, then we'll see. This one.
May I thank all the chairpersons and speakers at this session, the expert panelists, and all those who joined us from the two live theatres. Thank you very much. We move on to our next session. We move on to the next session, and may I request the chairpersons of the next session to please come to the stage. Dr. Pillai, Dr. Narayan Swarup, Dr. Shashikant, Dr. Arun Srinivas, and Dr. Sunil Kumar. In this session, we will have 4 speakers. We begin with Dr. Dalasi.
3.
No, you said
3.
we have 3 speakers. Yes, Dr. Anil Dhal, Dr. Raghu, and Dr. M. Josna.
Good afternoon, ladies and gentlemen. After that nice demonstration of live cases, we go on to 3 didactic lectures. May I call upon Dr. Anil Dhal to speak on CTO PCI LED stump occlusions. Is going to speak on CTO PCI in in-stent restenosis.
Can we have the slides? Good afternoon, everyone. It is a wonderful meeting. IJCTO every year is becoming larger, and because of the tremendous educational value, you can see the audience in the post-lunch 2 halls being full. That's a great achievement, as well as a recognition for all the hard work put by all the directors of the course directors. Thank you for this opportunity to present on in-stent restenosis, chronic total occlusion, angioplasty. So we all know that patients, as we have seen the live cases, CTO angioplasty remains the most challenging technical segment of the angioplasty in contemporary interventional cardiology. But what happens is, when you look at these, out of these patients, despite we beating a lot of drug-eluting stents, there is a significant chunk of these patients, about 5 to 25% of these CTO PCIs are because of in-stent restenosis. So that means CTO and following a stenting is not an uncommon problem. What happened is, the success rate with angioplasty with the CTO has improved. As you can see now, today morning also we had a huge success. About 90% of the angioplasties are successful with the native vessel, whereas native means without stent. Whereas in the past, for the CTO of the in-stent restenosis, we used to have a success rate of about 60 to 70%, but as we went forward, the success rate with the newer techniques and technologies, the success rate is as close to that of a non-stented CTO. So CTO angioplasty in the stented also very high success rate. But what is the Achilles heel of this problem? The Achilles heel of an ISR-CTO is a restenosis and repeat restenosis and a need for a repeat revascularization. So for us to understand this topic, I am going to put it into two halves. One half is to understand what causes this restenosis and how we are going to attack this problem. The first thing is there are a lot of data which has appeared in the last 2 years regarding the ISR-CTO, and when we looked at the pathology of the ISR-CTO between a drug and a bare metal stent, if you see nowadays in India also we have majority of the stents are drug coated. So we have about 67% of the ISR-CTO is due to an early thrombotic occlusion. And restenosis happens in about 8%, neo-atherosclerotic plaque is in about 4%, and when they looked at in this pathological study, what they have found is the proximal cap is abrupt cutoff with a BMS more frequently compared to a drug coated, and the length of the proximal fibrous cap is more with a bare metal stent and less with a drug coated stent. But if you go further forward, the distal fibrous cap is very short in a ISR-CTO. So if you look at this slide, you need to understand that in a drug-eluting stent, the restenosis is due to stent under expansion, because of which the stent gets thrombosed and it gets occluded and becomes a CTO. So you need to optimize your result and give a very good result in the beginning so that you do not have instant restenosis in the first part. The second learning part from this session, from this presentation, from this is, if you look at the distal lumen taper tip is about 74% in a DES. So what it indicates is if you have got a restenosis of a DES stent, you will have a much higher success rate if you go retrogradely rather than going antegradely, because that cap is longer and tougher when you go antegrade. So retrograde might be successful in a DES restenosis. So this is the same data published last year from the CVPAP group, showing the same in a pictorial graphic representation. Now let us come to another point. So this is a pathological data. Now we come to the intravascular ultrasound and our clinical data, because as cardiologists we want to look at what happens, what is my IVUS picture, what causes restenosis, early versus late. So you can see this is one more study which was published last year. You can see in the upper part, so the green represents a long-standing restenosis and red represents a younger restenosis. So for those patients who had an younger restenosis, the major cause for the restenosis happening within the first 3 years is due to stent under expansion. Whereas if the restenosis is happening beyond 8 years, this is due to neo-atherosclerosis. So the pathology of restenosis is totally different. So what does it have? That the bearing, another thing is if you look at the drug versus the bare metal stent, the drug eluting stent has got more of neo-intimal hyperplasia and stent under expansion. So you need to do a good job when you put a drug eluting stent to prevent the problem of restenosis, and if it is beyond a certain time, it is due to the intrinsic characters of the plaque like a neo-atherosclerosis that is responsible for that. Now, let us come on to an approach, how we approach an instant restenosis is based upon the CTO score. Morning, Dr. Yamane also has shown this latest, what we call as the algorithm from the Asia Pacific group, showing how do you approach a CTO. The most important thing is you need to study the CTO angiogram. If you got both the proximal and distal caps within the stent, then what happens is it is difficult for you, it will be very easy if you use a subintimal tracking and dissection and re-entry. Whereas if one part of the lesion is beyond the stent, then it becomes little difficult for you to go subintimal tracking, dissection and re-entry track. So you need to study the proximal cap, you need to study the length of the lesion, you need to see whether the lesion is beyond the stent or within the stent, and also whether there is an antegrade flow. Based upon that, you can take a probable approach, whether you want to go retrograde, whether you want to use a crossboss, or whether you want to use a nice Felder XTR and cross the wire and do a good optimization of stent, the timing from when you had done the stenting and when the restenosis has happened, and all those things you can look into it. What causes the restenosis being more difficult to open is because there is a lot of metal there. The metal is underexpanded, so wire tracking is difficult. Stent fracture could be there, and because it's a chronic fibrous plaque and a high chronicity, it will be difficult for you to open. An article which was published in the last year in the JAC interventions clearly shows what all points which we discussed till now, showing that a tapered tip which you can use an antegrade without an antegrade, and what are the mechanisms. Now let us come to like what you have seen this morning. If you are going outside the stent, you have to direct within the stent. If you are going beneath the stent, it is very difficult for you to re-entry, so you should avoid it, and possibly use of imaging is very important in that. Crossbar stingray, I think there is one more session, but let me show you two recent presentations, one from 3 centers in Italy and another from the Spanish from about 17 centers, which what you can see is, as you can see in these lesions, when you go to the next thing, despite doing a successful angioplasty, the repeat revascularization for an instant restenosis is about 16% compared to a de novo CTO of about 9%. So the problem right now is if you have an ISR-CTO, you might have to do it again. So how do we overcome this problem? The similar result also have appeared in the Euro intervention of the Spanish group, which shows the success rate of angioplasty is increasing. But what is happening is the result, whether the important thing is the stent thrombosis and the cardiac mortality are also everything comparable between both the groups. But once again, the repeat revascularization rate, restenosis rate is also, in this study is also about 15%. So we need to understand how we can do better for this ISR-CTO PCI. The important thing is we need to do, in this, both the studies, they had a use of IVUS in Italy and from Antonio Colombo and other groups, and also from Spanish, the use of IVUS was only 10% and another study about 13%. So multimodality imaging is one of the important things wherein you can optimize your result, and then before procedure you can do IVUS to understand what is the cause for the IVUS ISR, use of debulking devices, possibly use of a laser, use of DEB, DES, or both DEB and DES is important. Another important thing is, let us not chase a small CTO with a very small distal vessel or something like that, because if you start doing this and create more of a microinfarct and a PCI-related infarct, you can have problems. So you need to be understanding which to treat medically, which to do an angioplasty. And very importantly, whenever we do these type of ISR-CTO angioplasties, we need to tell them the need for a repeat revascularization again, because this is a group of patients where we can have a trouble. I don't know whether I have got about a minute or more. I can try to show you a case, but if we don't have time, we can go forward. We can take it up. Okay. It should be playing the video. Wait a moment. It's playing there. Okay. I cannot see here. It's not playing here. Okay. So what's happening is, okay, so we have a chronic total occlusion of the right coronary artery. I can see here. So what we did for this patient is like use of an anchor balloon to stabilize the guide catheter, advance the wire always within the lumen, and when we advance the wire, a simple tips, because this is a patient with a instant restenosis of the right, where we need, when we did an antegrade tracking, we have used a Gaia wire, and I think the second wire what we used was a Conquest 12, and then once we crossed it, we need to check the wire, like in morning Dr. Pratap's case, how you can go into the lumen, take 2 orthogonal projections, try to bring the wire into the lumen. Once you bring the wire into the lumen, After that, the procedure is straightforward, simple. So what I would like to show with such a sort of long CTO, we used a 3.5 millimeter stent, and then this is the final angioplasty. So what I am trying to show, what I would like to conclude is ISR-CTO is a significant chunk of our patients who undergo angioplasty. We can do a much better job. There is no need for us to send these patients for surgery. We can do better if we use imaging and optimize the result. And when you have a restenosis, use multiple modalities to treat it rather than only one modality. Thank you all. Thanks for your attention.
Due to lack of time, we are not going to allow any questions. I think there are two more presenters. Yeah. So the next presenter is Dr. Jyotsna. Retry CTO PCI. Specific challenges.
Namaste. Good afternoon to everyone. Today we are going to talk about the retry CTO PCI. Before that, I wanted to talk retry CTO PCI and what things to consider when we want to do the retry the CTO PCI and the summary of it. What are the main reasons for the failed CTO PCI? Whereas we already know it, when the wire enters into the subintimal space, it produces the big hematoma, which longitudinally and horizontally it is an extends and compresses the true lumen. This is one of the example of the patients who died following the CTO PCI. Pathology is demonstrating such an extensive hematoma compressing the true lumen. So when you wanted to retry the PCI, again the IJCTO score is essentially important. If it is 1, that is an intermediate, then it is more likely to that we have the success rates. And when to consider the CTO PCI, that is the most important. Each case which is failed, we need not to consider the redoing once again. So what we have to pay attention is that the first attempt, if there are no serious complications occurred, like a coronary rupture and cardiac tamponade, contained perforations can be tried. Irreversible damage with a contrast-induced nephropathy or radiation dermatitis, collateral channel perforations, even though they are healed, they are likely to be the bleed second time when you do it once again, and stent placed in the subintimal space, then in these conditions, again they're trying to cross and do a justice to this CTO PCI may not be have a good result. So otherwise it is better to do retry CTO PCI as long as proper resources are available. And the best candidates are previously only wire attempt without aggressive wire manipulations. I will show the few of the examples where we can attempt it than leaving them. Like in this patient, if you see it, is that playing there? Can you have the play, because I am not able to see it here. They're playing, okay, that's good. It is then CTO, then RCA, and the dual injection is demonstrating that is the collaterals from the epicardial of the circumflex, epicardial collaterals from the circumflex, and few of the septal collaterals from the LADL, filling the whole of the LAD. So we took that as a guide to advance our conquest. But when we tried a little bit harder, we realized that it is out of the plane, and that is the end result.